third series of ECG lectures I had for this since this September. Kasi nagle-lecture din ako ng ECG among interns and residents. So, yung sa book nyo, all about rhythm abnormalities lang, but I just want to show you that in ECG we can also identify chamber enlargement, ischemia, or infarction. But for your exam, this will all be about rhythm abnormalities. Okay. So just a little review: before the heart contracts, it must be electrically stimulated. And for the electrical stimulation to occur, there must be depolarization of cells. Starts with the P wave. It is conducted to both atrium and then to the AV node, and then to the right and left bundle branches, and then Purkinje fibers. And that's the time that the ventricles will contract after the QRS has been formed. And then once all the contraction of the ventricles happened, the repolarization starts. That's where you produce the T wave. And after the T wave is produced, that's where the actual ventricular relaxation happens. So we cannot see on ECG the atrial relaxation because it is buried beneath the QRS complex. So the normal sinus rhythm is defined as the conduction is coming from the P wave, from the SA node, and that's the reason why there should be the presence of a P wave followed by a QRS complex at a regular rate. Meaning in all beat, there should be PQRST. Otherwise, if it's just a P and then no QRS complex, it means to say that the SA node has conducted, but has fired or has produced an electrical stimulation, but the electrical conduction did not pass through the ventricles. So the sinus rhythm, to say that it's a normal rate, should be between 60 to 100. If it's more than 100, it means tachycardia or sinus tachycardia. If it's below 100, we call it sinus bradycardia. So for you to look at the ECG, you have to closely look at the P, and then it should be followed by a QRS complex, and then a T wave. That's a complete beat. And in every beat, all the important waves should be there, the PQRST. So part of the definition of a normal sinus rhythm is that the PR interval should also be less than 0.20 seconds or 200 milliseconds. Because even if there is a PQRST in every beat, and the heart rate is, let's say, between 60 to 100 beats per minute, but the PR interval is more than 200 milliseconds, we still call it a normal sinus rhythm, but with a first degree AV block. We will talk about that in the next slides. So I have put there a cycle length that does not vary 10%. So if it should be regular from R to R interval, it should be the same, and the P to P interval should also be the same. But sometimes there are changes a little bit. As long as less than 10%, hindi natin i-comment yun. We will just say it's a normal sinus rhythm. But let's say the cycle length is more than 10%, then we call it normal sinus rhythm with sinus arrhythmia. And we will talk about sinus arrhythmia in the next slides. Okay. So all the waves should have the same contour. Even if there are PQRS but different contours, it might be, let's say, a premature atrial contraction or a premature ventricular contraction. So dapat pare-parehas. And the P waves should be upright in all leads except AVR. There are some variations. Let's say in B1, B2, the P wave can sometimes be inverted but still normal, and these are seen in female with big breasts. So their P wave are somehow inverted. So, but most of the time, P waves are upright in all leads except AVR. Kasi in AVR, it should be inverted. Pag yung P wave is upright in AVR, it means to say it's either bali yung pagkakalagay ng leads or something is really, really wrong with the SA node. And all leads again should be followed by a QRST. So you have to fall in love with a normal ECG rhythm, because if you do not know normal, mahirapan kang mag-identify subnormal. Anything that deviates from the normal is arrhythmia. And that's the topic for today. So the steps in interpreting an ECG, you need to identify the regularity, and then you have to identify the rate. Kailangan alam niyo mag-identify yung heart rate ng isang ECG kasi most of the time the heart rate is written below the ECG strips. But what if walang nakasulat? So you should know how to count or identify the heart rate. And then identify the rhythm. When we say rhythm, is it sinus? Is it atrial fibrillation or junctional rhythm or atrioventricular rhythm? So kailangan yung alam yun. And there should be a PQRST, and you should be able to identify the intervals. The PR interval is important at this point in time na kayo first year kayo. Yung QT interval maybe pag mga third year or interns na kayo. But ngayon, PR interval dapat alam na alam niyo. When we say rhythm abnormalities, sometimes it's ventricular fibrillation or atrial fibrillation, and we will talk about this in the next slide. Clinical correlation, hindi pa importante sa inyo. Okay, regularity. So you have to visually look at the P2P and the R2R interval. It should be the same. Kung gusto mong manigurado, you can get a caliper, or you can get a paper and then you measure the R2R interval and then i-check mo sa ibang beat kung pare-pareha sila. In the same way, yung P2P interval. Okay? So it should all be the same, lahat ng P2P and R2R interval. So let's try to test. Is this regular or irregular? Ano sa tingin nyo? Anybody? For participation? Visually lang, tingin nyo. Is it regular or irregular? Meaning the R2R interval, is it the same or not the same?
Regular.
Regular.
It's regular. So this is the time that you have to be visually exercising to look at an ECG if it's regular or irregular. Okay? Next. Is this regular or irregular? Ano sa tingin nyo? Irregular. I agree to that. But there are PQRS in every beat. So somehow, normal siya na naging irregular. So this is a typical example of a normal sinus rhythm with sinus arrhythmia. And hold on to that. I will talk about sinus arrhythmia in the next slides. How about this one? Is it regular or irregular?
Irregular.
Regular.
It should
Regular.
lang nabibingi ako ha. It should be
Irregular.
okay. So ibig sabihin hindi magpare-parehas. And in this particular example, parang nag-iiba-iba yung morphology ng P wave. So something must be wrong with the AC node conduction. Okay, how about this one? Is it regular or irregular?
Irregular.
About this one, regular or irregular? Ano yun?
Irregular.
Regular.
Regular po do.
Meaning pare-parehas sila, same yung distance ng lahat ng beats. So regular siya. So that's the first step in identifying an ECG. You look at visually if it's regular or irregular. Kung gusto mong manigurado, again, then you measure from the R2R interval and then i-check mo kung parehas sila sa lahat ng beats. Okay. How to determine the rate? Ito na yung kailangan nyo ng a little bit of mathematics. So you have to measure from one R2R interval how many small squares. And then this is the most accurate. It's 1,500 divided by the small number of squares. Okay, so for example here, up to this point, so 5 kasi yan eh, yung big square is 5 small squares. So 1, 2, 3, 4, 5. So this is 5, 10, 15, 20. Parang mga 2.5, pero sabihin na natin 23. So 1.5 divided by 23 is 65. So that's the heart rate, 65 beats per minute. Okay? Ganun lang siya kasimple. Nakuha nyo? Alam niyo man bakit yung constant number is 1.5 because in 1 minute, there are, every small squares kasi is 0.04. So 60 divided by 0.04 is 1,500. Okay. Ibig sabihin in 1 minute, there should be like 1,500 milliseconds. Okay. So there is a fast method, but hindi ka na pwedeng mag 62, 63 na ganung heart rate. Parang 300, 150, 100 lang. So paano ba siya? Big square is 300. The next big square is 150. Then 100. 75. So this is 60. So the heart rate is between 75 to 60. So at least you can approximate na normal sinus rhythm. I mean, within the normal heart rate yung pasyente. So ito yung fast method. Kung wala kang calculator, i-memorize mo siya. 300, 150, 175, 60, 50, 40, 30, 20. So visually lang. Pero di ka pwedeng kung the fast method ko, di ka pwedeng magsabing 63 yung heart rate. Doon mo lang siya makukuha if you use the 1,500 by the small squares from R to R interval. So 300, 150, 130. This is the most accurate. So for example, in this particular 60, so the heart rate is between 75 to 60. 60 to 75, sorry. So, yun, correct siya. Okay. Meron din namang 3 seconds strip, meaning to say, you just count the number of art 4, 5, 6. So 6 times 10, 60 beats per minute. Pero pwede namang seconds, 6 second strip. Pag sinabi nating 1 second, ibig sabihin 5 bigger square yun. So 1 or 5. So 1, 2, 3 second strip. Pag 6 na yan, 6 second strip. So you have to count the R interval within that second strip. So 1, 2, 3, 4, 5, 6, 7. That's the heart rate is 70 beats per minute. But again, hindi ka pwedeng mag 71, 72 in the 3 second and 6 second strip. Yung pinaka-accurate is the 1,500 divided by the small number of squares in an R2R interval. However, in let's say atrial fibrillation, nag-iiba-iba na kasi, masyado kasi siyang irregular, and that's why hindi magiging accurate. Kasi kung doon ka magbilang ng R2R interval in parang wide R2R interval, magiging bradycardic. Tapos doon ka naman pumili sa narrow or small R2R interval, magiging fast yung heart rate. So ang magagamit mo yung 6 second strip pag may atrial fibrillation siya. Okay? So interval, sinabi ko na to when we say PR interval, it's from the beginning of the interval, less than 200 milliseconds. QRS complex or QRS interval is from the beginning of the Q to the end of the T, and it should be less than 120. And then QT interval, magkakaiba-iba na tayo kasi it should be QRS complex to the end of T. Some books, it says up to 50 yung QT. Akong ginagamit ko 50, but in books, it's 46 in male, 48 in female. Nagkakaiba-iba na yung gamit. So, ako ginagamit ko na lang is 50 kasi pag more than 50, sure na ako to na talagang there's a prolonged QT. Yun, as first year, kailangan ang alam niyo lang is the PR interval and the QRS interval. Wag na muna yung QT. Okay? Alright, so arrhythmia recognition, ito lahat yan. So we will talk about slow rhythms, today and some benign rhythms. And the next lecture, we will talk about fast rhythms and arrest rhythms. Yung miscellaneous, we will not discuss this anymore. So hindi na rin siya kasama sa exam. Okay. Easy daw ang arrhythmia because you just have to identify if it's either fast or slow. If it's slow, then you go to the slow algorithm or bradycardia algorithm. If it's fast, then you go to tachycardia algorithm. So today, puro tayo slow algorithm. Okay, but before we talk about the slow rhythm, let's talk about the benign rhythms muna. So sinus bradycardia, although it's on the bradycardia algorithm, but it's can most of the time be benign. Ibig sabihin, you just have to observe the patient and then don't do anything about it. Benign lang siya. So, ano to yung sinus bradycardia? Ito yung there is a PQRST in every beat and the PR interval is normal. The P2P interval is normal or same. The R2R is the same. But the heart rate is just below 60 beats per minute. It means to say that the source of electrical impulse is coming from SA node, but the firing rate is just low. And you see this in, let's say, athlete. Kasi yung athletes kasi, because of their rigid exercise, they have this thicker left ventricular muscle. And so there is that stronger contraction in every beat, and they are able to expel a bigger stroke volume in every beat. And that's why they don't need a fast heart rate kasi marami na yung stroke volume nila. Kaya bradycardic sila. Okay? So, pag ganyan, normal lang yon. Kahit bradycardic sila, normal sa kanya. May mga taong ang heart rate talaga 55 beats per minute. And so if you do an ECG, magiging normal, sinus rhythm siya, pero magiging bradycardic. So sinus bradycardia ang tawag. Okay? So this is another example of sinus bradycardia. There is a PQRST in every beat, PQRST in every beat, and P2P interval is the same, and visually the R2R interval is also regular. But the heart rate here is so slow. So bilangan nyo na lang. So para to 5, 10, 15, 20, 25, 30, 34, 35, 36. So 1,500 divided by 36, yun yung heart rate niya. Sobrang slow. Okay? So sinus tachycardia can also be benign because there is PQRS in every beat, and then the P2P interval, R2R interval are all the same. It's just that the heart rate is above 100 beats per minute. So you can see this in, pag mag-exercise ka, for example, resting ka, 75 beats per minute ka, and then nag-treadmill ka, talagang bibilis yung heart rate mo, and then nag-ECG ka, it will appear as there is sinus tachycardia. So it's a benign rhythm. So you will see some patients na kinakabahan habang nag-ECG, so aabot sila ng 105, 110 beats per minute. So benign lang yun. Okay? You just have to observe the patient and then treat the cause. Kasi fever, for example, can increase heart rate, or an increased sympathetic activity can increase heart rate. So there are drugs that can either increase or decrease the heart rate. So it will appear as their sinus tachycardia or sinus bradycardia. So these are benign rhythm. Okay, another example of sinus tachycardia, PQRS in every beat, and this is regularly looking R2R interval and P2P interval. All right? So ito na yung sinasabi kong sinus arrhythmia. Ang nangyayari nito is that the AC node is firing, and then it is conducted all through the entire conducting system. And that's why there is PQRS in every beat. But the rate varies. Minsan 94 beats per minute, minsan 71, 79, 94. So nag-iiba mo more than 10% yung irregularity niya. So R2R interval visually is irregular. And this happens to young patients na masyadong fast and deep yung pag-breathe, because deep breathing can change the heart rate. When you inhale deep, there is an increased sympathetic activity. That's why the heart rate becomes faster. And when you exhale deep, there is increased parasympathetic activity, and that's why there is slowing of the heart rate. And so pag nag-ECG ka ng isang pasyenteng tachypneic, the ECG will appear as there is normal sinus rhythm and sometimes between 60 to 100, for example, pero nag-iiba-iba siya. So that's sinus arrhythmia. You will read that as normal sinus rhythm with sinus arrhythmia. Did you get that? So there's still PQRS in every beat, but the R to R interval is visually irregular. However, ano pa rin, galing pa rin sa SA node yung conduction. So that's sinus arrhythmia, and this is because of the effect and stimulation. So sympathetic and parasympathetic activity, either the patient is inspiring or expiring. So this is another example of sinus arrhythmia. There is PQRS in every beat, but visually it's irregular, and this is normal sinus rhythm with sinus arrhythmia. So pag mag-exam tayo, sinus arrhythmia, okay na yun. Pag normal sinus rhythm lang, 0.5. Pero pag normal sinus rhythm with sinus arrhythmia, 1 point. Ganon, okay? Pag sinus arrhythmia lang ang sagot mo, 1 point na yon. Okay? Kasi I'm trying to test your thought process about. Okay. So paulit-ulit lang during inspiration, increased sympathetic activity, that's why the heart rate is faster. And during expiration, there is increased parasympathetic activity, and that's why the heart rate becomes slower. So sympathetic and parasympathetic activity can affect the SA node, firing ability of the SA node. So if there is increased sympathetic activity, there is increased firing rate of the SA node. That's why nagiging faster yung heart rate. And parasympathetic naman, it inhibits or slows down the firing rate of the SA node. That's why the heart rate is slower. Okay, premature atrial contraction is another benign rhythm. It means to say that somewhere firing at a faster rate than the SA node. That's why it overrides the SA node and it conducts through the AV node to the ventricles. Okay, so for example here, galing dito yung, there is probably an infarction in the left atrial muscle here, and it has produced an electrical activity faster than the SA node, and that's why it was able to conduct through the AV node. So PQRST galing SA node, PQRST galing SA node, and then if you look at this beat, dapat kasi yung next beat should have been about here, if I have to approximate, dito siya. Pero this beat is earlier than expected. There's a P, QRST, but if you look at the P wave here, it's bizarre looking, parang kakaiba siya, parang bifid siya, dalawa. It means to say, hindi siya galing sa SA node. And most of the time in a premature atrial contraction, the PR interval is narrowed because most of the time the origin of the electrical impulse is near the AV node. Kaya it will mabilis siya makapag-conduct to the AV node, and that's why the PR interval is narrow or shortened. But I give you an example kasi it sometimes be prolonged. Pag malayo, for example, in this particular case, the origin is in the left atrium, superior portion of the left atrium. Malayo yung tatravela niya to the AV node, and that's why the PR interval is also prolonged. So that's an example. Now, the QRS complex is narrow because the electrical impulse is coming from the atrium and it has passed through the AV node, bundle of His. So sa Purkinje system pa rin siya dumaan, and that's why it's a narrow complex QRS. Okay? So let me just clarify that if the electrical impulse to the ventricles is through the conducting system, it will produce a narrow QRS complex. But if the conduction of the electrical impulse is outside the conducting system, meaning to say muscle to muscle yung conduction, the travel time of the electrical impulse is longer, and that's why the QRS complex is widened. Okay, so since in a premature atrial contraction, although the origin of the electrical impulse is not coming from the AC node, but this electrical impulse conducted to the AV node and then to the normal Purkinje system or normal conducting system in the ventricles. And that's why there is this normal or narrow QRS complex. So just to clarify, a premature atrial contraction is a beat that is earlier than expected. There is a different contour or configuration of the P wave, which signifies that the origin of the electrical impulse is not coming from the SE node. The PR interval is most of the time is narrow or shortened, but it it's not hard and fast rule. Sometimes it can be longer, sometimes it can be normal. It will depend as to where the electrical impulse is coming, if it's nearer or farther than the PR interval. But in premature atrial contraction, the QRS complex is narrow because the electrical impulse travels to the normal conducting system in the ventricles. Okay? So this is another example of a premature atrial contraction because the next beat should have been here, but it appeared earlier than usual. And that if you look at the P wave, it's different contour or configuration to the normal P wave. So kakaiba siya. The PR interval, I would say, is a little bit prolonged in this case. But the QRS complex is narrow. It means to say that the conduction to the ventricles is through the normal conducting system in the ventricles. All right? So this is different from a premature ventricular contraction, and that's because somewhere in the ventricles, let's say you have an infarction in the ventricular muscles, and this infarcted cell produce an electrical impulse that is faster than the is a node. And so it will override the is a node. But this time, the electrical impulse is coming from the ventricles. So it will travel from muscle to muscle. And that is the reason why the QRS complex is wide. And since it's coming from below, there will be no P wave produced. Okay? So again, it will produce a bizarre looking wide complex QRS because the electrical impulse is coming from the ventricles, and then the travel of the electrical impulse is not through the normal conducting system, but through muscle to muscle. And then once the electrical impulse has reached to the conducting system, it will now go to faster. Parang it will now spread faster to the Purkinje system, but still it will produce a wide complex QRS. Now, if you look at the T wave, it will always be opposite to the QRS. Okay, so kung pataas yung QRS, pababa naman yung T wave. Kung pababa yung QRS, tataas naman yung T wave. And there is this complete compensatory pause following every premature beat. And ito na yung mahirap-hirap. So we have to focus more on explaining compensatory pause. So, ang nangyayari sa premature ventricular contraction is that the electrical impulse is coming from below. So, since it's coming from the ventricles, it will not affect the firing rate of the SA node. And so the next, maghihintay siya to the next firing of the SA node. And that's why there is this prolongation after every premature beat. Now, I will differentiate that in the next few slides. So this is another example of a premature ventricular contraction because the next beat after this should have been here, but you see this bizarre looking wide complex QRS that is earlier than expected. There is no P wave because this is a T wave from this beat. Kaya this beat has no P wave, which means that the origin of the electrical impulse is coming from below the atrium, which means it's coming from the ventricles. That's why there's no P wave. And it's a wide complex QRS because the electrical impulse is traveling through muscle to muscle. And if you look at the T wave, it's opposite from the QRS complex pababa siya. Unlike in a normal beat, the T wave is upright. Ito, the T wave is inverted or opposite to the QRS complex. And as you can see, there is that compensatory pause kasi kung nag-beat siya, dapat dito siya uli yung next beat. However, you have to wait kasi yung SE node has its own firing rate. It will fire kung time na niyang mag-fire. Kunwari, if it's firing at 65 beats per minute, it will really fire sa pang 65 beats per minute lang. It will not fire earlier kasi the conduction started, the abnormal electrical impulse originated in the ventricles. It will not affect, it will not reset the firing rate of the SE node. Okay, so these are types of PVCs. It can be multifocal, ibig sabihin iba-iba yung shape ng PVC. Ibig sabihin, pag multifocal, iba-iba yung origin ng electrical impulse. Maybe there are a lot of infarcted ventricles or ventricular muscles that is firing faster than SE node. That's why it's able to conduct earlier than expected. And that's why, since magkaiba-iba yung location, magkaiba-iba yung shape ng or morphology of the premature ventricular contraction. So this is an inverted PVC, this is an upright PVC. So we can say that it's couplet. Ibig sabihin, magdalawa sila. Pero pag paisa-isa lang, pwede natin tawagin siyang occurring singly, a premature ventricular contraction occurring singly. Or pag dalawa na sila, we will say it's couplet. However, pag maging tatlong sabay-sabay na ang ang PVC, we will now call it a non-sustained ventricular tachycardia or a VTAC na siya. Okay, let me clarify. When we say sustained versus non-sustained, a ventricular tachycardia more than 30 seconds is sustained ventricular tachycardia. Pag less than 30 seconds, that is a non-sustained ventricular tachycardia. So, dalawang PVC, tawag niyan is couplet, premature ventricular contraction. But once it becomes a 3 premature ventricular contractions, we will now call it, hindi siya triplet PVC. We will call it a non-sustained ventricular tachycardia. So in this particular example, apat na sila na sabay-sabay, we will now call it a ventricular tachycardia. So a PVC can induce ventricular tachycardia if it's what we call as an R on T phenomenon, meaning to say that the PVC started during that absolute refractory period. Hindi pa kasi bumababa yung T wave eh. Tas doon siya nag-start. So if it's an R on T phenomenon, meaning the premature ventricular contraction is started during the absolute refractory period, it can initiate a ventricular tachycardia or even a fibrillation, and that's deadly. But unlike in this example, for example, tsaka. So in this example, so the PVC started complete na yung repolarization. Agree kayo, di ba? So bumaba na yung T wave. Dito siya nag-appear yung PVC. So in this particular example, ang PVC mo is trigemini because normal beat, tas PVC trigemini yan. Pero for example, normal beat, tapos you have a PVC, we call it bigemini. Pwede ding quadrigemini. Ganon. Pag every 4 beats siya. Okay? Hi. So ito na yung how we differentiate a compensatory pause versus a non-compensatory pause. Kasi a premature atrial contraction, for example, this is a PAC. This is a PAC, so normal beat, this is a PAC. It also has a pause here, but we call it non-compensatory pause. This is a PVC, and there is that pause here before the next normal beat, but this is called a compensatory pause. So ano ba ang compensatory pause? What happens in premature atrial contraction is that the contraction, the origin of the electrical impulse is coming from the atrium. And because it's coming from the atrium, it will affect the SE node, meaning it will reset the firing rate of the SE node. Magiging, kung dati 65 beats per minute siya, tapos nagkaroon change, maybe 70 beats per minute na. And that's why nag-change yung next beat niya. Kaya mag-iiba yung distance. Samantalang in a full compensatory pause, in a PVC, the origin of the electrical impulse is coming from the ventricles. It will not affect the SE node. It will not reset the firing rate of the SE node. And that's why the the next beat will always be the same, and we call it compensatory beat. So how to check for that is that, okay, how to check for a full versus non-compensatory pause is you compare it with a normal heart rate, dapat tatlong beat. Okay, you measure from P to P, dapat ma-check mo yan yung distance. And then you compare, it will be the same distance in a P to P in between a PVC. But in a premature atrial contraction, magkakaiba yan. The P to P in between a PEC, magiging iba siya. Ito naging longer, no? Dapat itong beat na to, maybe dito pa siya. Dapat dito pa siya nag-start. Pero ito, nag-start siya earlier because the origin of this premature atrial contraction is coming from the atrium. Dumaan siya sa SE node or naapektuhan niya yung SE node. So it has reset the firing capability of SE node. That's why this one, nag-contract siya earlier than expected. Pwede ding a little bit later. And that's why tatawagin siyang non-compensatory pause. Anyway, this will not come out on your exam. I just want to explain what's the difference between a full compensatory pause versus a non-compensatory pause. So in PAC, ulitin ko lang, the origin of the impulse is coming from the atrium. That's why it will reset the firing capability of the AC node, and that's why the compensation is different in all beat. Unlike a PVC, the origin of the electrical impulse is coming from the ventricles. It will affect the firing rate of the SE node. That's why it will always be the same. The compensatory pause will always be the same. Kasi maghihintay ka pa to the next firing rate of the SE node to be able to produce this normal beat. And that's why it will always be the same. All right. So if you look at this, a PVC, parehas sila sa tatlong normal beat. 1,360 milliseconds. Kasi hindi naapektuhan yung firing rate of the SE node. The SE node did not change its firing rate. Okay? How about in a PAC? So 1,640 milliseconds to, nag-iba na siya on the next beat. Parang 1,800 siya because there is resetting of the firing rate of the SE node. I hope that is clear. Talk about. So today, ang discussion natin is just slow rhythm. We already have talked about SE node, but the heart rate, it's regularly occurring, but the heart rate is just below 60. Okay. So this is an example of sinus pause. Okay. So, ano naman siya? Nakakaloka. So, nag-fire si SE node, followed by a QRST. Nag-fire si SE node, followed by a QRST. Hindi nag-fire si SE node. Kasi walang na-produce na PQRST. Yung next beat is here. It's like way longer than expected. We call it sinus pause. Okay? Nakuha niyo ba yon? Matagal lang nag-fire. So parang nag-pause si SE node for a longer period of time. Pero after that, nag-fire ulit siya. So a sinus pause will be sometimes a problem because pwede siyang mag-fire ulit si SE node. That's why it will produce this. After this, kunwari matagal siya, pwedeng galing pa rin sa SE node ang pag-fire niya, meaning PQR is the same pa rin. But sometimes, hindi nag-fire sa SE node. Nag-pause talaga siya. And the AV node will try to conduct, will try to fire or discharge an electrical impulse to save the contraction, I mean to produce an electrical contraction or conduction to the ventricles kasi sobrang tagal ni SE node mag-fire. So a sinus arrest or sinus pause, tatlo ang mangyayari yan. Either conduct uli sa SA node kahit natagalan lang o save si AV node, a fired electrical impulse. Or pwedeng the ventricle, si AV node, tanga-tanga lang din, hindi nag-fire. But the ventricles will try to conduct. Kasi diba, you have other pacemakers. But yun lang. So, sinus arrest can have three. The next beat will either or galing sa AV node, meaning to say, narcomplex QRS pero walang P wave, or galing sa ventricles, okay, blocks second degree AV. First degree AV block, the delay lang more than 200 milliseconds, but every beat nakakapass to the ventricles. Every beat, there is conduction to the ventricle. I'm sorry. Pangit ang CV block. There will be like first beat prolonged lang or hindi prolonged pero nakakanda. The second beat prolonged yung PR interval and then hindi nakakandak. So there will be a time in second degree AV block that there will be complete block across the AV node. So it's like 3:1, meaning 3 beats able to conduct to the ventricles, but on the fourth beat, wala. Or most of the time, it's 2:1, meaning 2 beats are able to conduct to the AV across the AV node to the ventricles, but on the third beat, completely blocked. So wala nang nag-conduct to the ventricles. So that's second degree AV block. While a third degree AV block, not at all. All firing coming from the SA node is completely blocked in the AV node. Okay, so let's go to, so the problem in atrioventricular blocks is in the AV node. Somehow there is abnormality in the conduction across the AV node. So the first degree AV block is simply lang, the conduction velocity in the AV node is prolonged more than 200 milliseconds. So, but still able to conduct to the ventricles, nadidelay lang. In every beat, so P wave to QRS complex, meaning nakakonduct to the ventricles, but it's just so prolonged, more than 200 milliseconds. So in this particular example, the PR interval is 280 milliseconds or 0.28 seconds. So this is first degree AV block. Now, first degree AV block, the conduction to the AV node is just delayed, but albeit the electrical impulse is able to pass through or conduct to the ventricles. Okay? So you just have to, it's a normally looking PQRST regular, but sometimes it's bradycardic. It will produce bradycardia, but sometimes no, 860 to 100 beats per minute. But you have to be particular in looking at the PR interval, because if it's more than 200 milliseconds, then that's already a first degree AV block. So a first degree AV block can be seen in a normal sinus rhythm. A first degree AV block can be seen in a sinus tachycardia. A first degree AV block can be seen in sinus bradycardia, okay? But most of the time, we see that in patients with normal sinus rhythm, okay? So this is another example of a first degree AV block. So if you look at this, PQRST regularly occurring. Ano bang heart rate nito? Pakibilang nga. 5, 10, 15. So normal sinus rhythm, but first degree AV block. Okay? So the PR interval sobrang haba na, no? Parang 5, 6, 7, 8. 8 times 0.04, yun yung PR interval niya. Alam niyo naman siguro paano ma-compute yung PR interval. Kasi one small square is 0.04, so kailangan memorize niyo yun. So if this is 8, compute nga. 8 times 4, 132. 0.32, sorry, 320, grabe no? 320 milliseconds or 0.32 seconds yung delay to the AV node. So this is first degree AV block. Let's now go to second degree AV block. Don't be confused. Second degree AV block is also called Mobitz type 1. There are two types, type 1 and type 2. So it can be Mobitz type 1 or Mobitz type 2. Kasi si Dr. Mobitz, I don't know kung kailan siya pinanganak, German-Russian physicist na nag-aral about AV block. So, na-discover niyang if there is abnormality in the AV node, magkakaroon ng, merong times na there is complete block in the AV node. So ito yung type 1 or type 2. Ang type 1 is also known as Wenckebach. Hindi mo pwedeng sabihin Wenckebach type 2 kasi Wenckebach is just type 1. But Mobitz can be type 1 or type 2. But this is second degree AV block. Don't be confused. Not first degree AV block, but second degree AV block. And in second degree AV block, there is a type 1 or type 2. So what's the difference between a first degree AV block versus second degree AV block? In first degree AV block, there's a delay in the AV node, but all beat is able to conduct to the ventricles. But in second degree AV block, there are some beats that are able to conduct to the ventricle, but there will be a beat that will not be able to conduct to the ventricles. We call it a non-conductive beat or a drop beat. So if there is a drop beat, that's automatically a second degree AV block. So you have to differentiate between a type 1 and a type 2. So in type 1, second degree AV block, type 1 versus type 2, ang technique na gamit ko is you look for a P wave not followed by a QRS because that's a drop beat. Ibig sabihin, there is a node fired, but it was blocked, completely blocked across the AV node, meaning hindi siya nag-conduct to the ventricles. That's why there is no PQRST. Okay? So if you see a P wave not followed by a QRS, that is a drop beat. So from the drop beat, you look at the PR interval before the drop beat and the PR interval after the drop beat. Because if the PR interval is different, okay, this is longer, this is a little bit shorter, but they have a different PR interval, then that's a second degree AV block type 1 or Mobitz type 1, okay, or Wenckebach. So in second degree AV block type 1, the PR interval is prolonging until there is a drop beat. So ang nangyayari, nag-conduct to the AV node pero na-prolong na AV node, naka-conduct to the ventricles. On second beat, mas na-prolong pa sa AV node, let's say 400 milliseconds na, pero naka-conduct pa to ventricles. On the third beat, wala na talaga, completely black across the AV node, walang naka-conduct to the ventricles, and that's why there is no QRS complex. So that's a drop beat. Again, look for a P wave not followed by a QRS. If you see a drop beat, you look for the PR interval before the drop beat, and the PR interval after the drop beat. If the PR interval before and after the drop beat is different, that's a type 1, second degree AV block type 1. In this example, you look at the P wave not followed by a QRS complex. This must be a drop beat. Ang sabi ko sa inyo, you look at the PR interval before the drop beat and the PR interval after the drop beat. If they are the same, that's a Mobitz type 2 or second degree AV block type 2. Nakuha nyo? Okay. Tiwala lang. Okay. These are the example of a P wave not followed by a QRS. So this must be a drop beat. So we look at the PR interval before the drop beat. This is sobrang prolonged. And the PR interval after the drop beat, it's like a little bit narrower but still prolonged. So magkaiba, then it must be a first degree AV block or Mobitz type 1. Another characteristic of Mobitz type 1 is that the PR interval before the drop beat has the longest PR interval. And then the PR interval after the drop beat has the narrowest PR interval. Kasi pag drop beat dito, mag-i-start pa lang siya eh. So normal pa siya. That next beat after here probably would have been a little bit longer, mga 220. And then on the third beat, mga 300 na. On the fourth beat, completely black na siya. So ganun siya palagi ang sistema niya. So, but you just have to look at the drop beat and compare the PR interval before the drop beat and after the drop beat. If the PR interval is different, then that's Mobitz type 1 or second degree EV block type 1 or Wenckebach. Ulitin ko lang, the PR interval before the drop beat has the longest PR interval, and the PR interval after the drop beat has the narrowest or shortest PR interval in a Mobitz type 1. Okay, so there is progressive prolongation interval with each succeeding beat until one P wave occurs without a QRS. So this is what we call as a drop beat. All right. So a second degree, ang sinabi ko na to, the longest PR interval is immediately before the drop beat, and the shortest PR interval is immediately after the drop beat. Okay, so another example of second degree EV block type 1. This is a P wave not followed by a QRS. This must be a drop beat. You look at the PR interval before the drop beat and the PR interval after the drop beat. They are different, and this must be a second degree EV block type 1. So looking at this, the PR interval is prolonging and prolonging until a drop beat. Kaya these are the manifestations of a second degree EV block type 1. Again, the PR interval before the drop beat has the longest PR interval, and the PR interval after the drop beat has the shortest PR interval. In Mobitz type 2, it's fixed, meaning to say, ano lang siya, nakapasok on this beat. It was the beat, the SA node fired and was able to conduct to the ventricles. And then in the next beat, the SA node was able to conduct to the ventricles. That's why this is followed by a QRS. But on the third beat, the SA node fired, but it was completely blocked across the AV node. That's why it's not followed by a QRS complex. So ang technique is look for a drop beat. If there is a P wave not followed by a QRS, you immediately commit this as a drop beat, and then you immediately look for the PR interval before the drop beat and after the drop beat. If both have the same PR interval, it's automatically second degree AV block type 2. But if there is a difference in PR interval, prolonged yung PR interval before the drop beat and shorter yung PR interval after the drop beat, that's second degree AV block type 1 or Mobitz 1 or Wenckebach. Okay, so Mobitz type 2 has a fixed PR interval with intermittent drop beats. So normal yung P wave, but there is a P wave that is not followed by a QRS complex, and that's a drop beat. However, there's a fixed interval. So in this particular example, this is the P wave not followed by QRS. Then we look at the PR interval before the drop beat and the PR interval after the drop beat, second degree AV block type 2. Okay? Here, constant P2P intervals and R2R intervals. Nasabi ko na yan. Ito nang mas mahirap because a third degree AV block is like difficult for most students. So in first degree AV block, there is just a delay in the AV node but still able to conduct the ventricles in all beat. Second degree AV block, there are beat that are able to conduct across the AV node, but there will be some beat that are completely blocked. Pero meron namang ibang beat na nakakapasok to the ventricles. In third degree AV block, talagang any beat at all, walang nakakapasok to the ventricles. So the AV node blocks all conduction to the ventricles. So ang mangyayari lang is the P wave will be sending electrical impulse at a normal rate or at the same rate. So palagi siyang same to same yung P2P interval, in this particular example, is 80 beats per minute. Kasi makukompute mo yung rate ng P to P because you just count the number of small squares from P to P, 1/5 divided by the number of small squares, that's the heartbeat of the P to P. And then yung R to R interval are also the same. Pero kung titingnan mo, hindi na sila, it's dissociated. We call it dissociated because wala silang relationship. Akakalain mo tong this is a PQRST. Pero ito, PQRST pa ba to? Pwede pa sigurong sabihin mo. Pero ito talagang sobrang haba na nila ng distance. Hindi mo na alam kung drop beat na to or what. So, kailangan mag-isip ka, if all the PR interval are different, pero pare-parehas yung distance ng R to R at saka P to P, think of a third-degree AV block. Kasi if you commit this as a drop beat, di ba titingin ka ng PR interval before the drop beat and the PR interval after the drop beat? Walang PR interval to. So it should give you a hint that this must be a complete AV block. So what will happen is just the SE node will be firing on its own, and that's why you are producing a P wave. Ito siya. It will be firing on its own. And that's why palagi kang may P wave that is regularly occurring. However, all the P waves, all the electrical impulse coming from the SE node is completely blocked in the AB node. So ang mangyayari, si ventricles, naghintay lang siya ng hintay, sobrang walang pumapasok, and that's why it will fire. There are pacemaker there. Let's say the bundle of his will fire on its own, and but it will be slower kasi yung firing rate ng bundle of his is like 40 to 60 beats per minute. So it will be lower. So that's why the heart rate here will be like 40s. So the ventricles will have an escape beat. We call it an escape beat because nag-fire na yung pacemaker nila. It will be at 40 beats. It will not be faster than the SE node kasi nga the pacemaker below the AV node is always slower than the SE node. So kung titingnan mo dito, same distance yung ventricles, 43 beats per minute, and regular din yung atrial rate at 80 beats per minute, but wala silang relationship. It's completely dissociated. So complete AV block, the impulses originate from both AC node and a subsidiary pacemaker below the block. And that's why there is a wave. And that is also the reason why there is a QRS complex, but they are completely dissociated. So one criteria for a third-degree AV block is an atrioventricular dissociation. Okay? So let's just try to dissect this one. So this is a P wave not followed by a QRS. If this is a drop beat, walang PR interval dito eh, pero dito merong PR interval. It does not follow the second degree AV block that we have talked about. Okay? This is another P wave. So kung titingnan mo, no, parang somehow there's a P wave here, a P wave here. Ito may P wave, dito may P wave, dito may P wave. So regularly occurring siya. And then the ventricular rate is also regularly occurring. So bradycardic yung ventricular rate, tachycardic or normal rate yung P wave, there is a complete dissociation. Okay? Mahirap siya at your level, but ang nakakatulong sa akin is if the PR interval in all beats are nag-iiba-iba. Ito PR interval niya parang ganyan siya. Ito sobrang haba. Ito naman sobrang sobrang narrow, shortened. Ito naman wala talaga. So if all the PR interval are changing, now I look at P waves. If the P waves are regularly occurring, then after that, I look at R to R interval if they are regularly occurring. Then I can deduce that the ventricles are contracting or firing at the same rate, and then the AC node is also firing at a regular rate, but they don't have relationship to one another. We call it atrioventricular dissociation. This must be a third degree AV block. Okay? All right. This is another example. So look at this PR interval. Look at this PR interval and the P interval here and the PR interval here. Magkakaiba sila. So there must be something wrong. If you look at this at drop beat, PR interval here is different from the PR interval here. Parang pwede siyang second degree AB block type 1, pero di ba sa second degree AB block type 1, the PR interval before the drop beat should be longer than the PR interval. Ito, baliktad na siya eh. Mas mahaba na after it does not follow the criteria for a second degree AB block. So it will now give me a hint. Baka something is wrong. Not second degree AB block, not first degree AB block din siya because pwede tang first degree AB block, pero nag-iiba-iba kasi siya yung PR interval. Eh. So, not first degree AB block, not second degree AB block. So, let's look at the P2P if they are like regularly occurring somewhere here. Merong P siguro dito. P, 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 P. Parang regularly occurring, no? And then, if you look at the R to R interval, also regularly occurring, then think of it as the ventricles are contracting regularly, and then the SE node is also firing regularly, but they are completely dissociated. This is third degree AB block. Okay? I hope natulungan kayo. Junctional rhythm is, yung concept niya is easy, but sometimes this is difficult to students. The concept here is that the SE node did not fire, and that's why the AV node now ang naging pacemaker mo. Kaya the AV node will be firing at a slower rate, below 60 beats per minute. And so because the AV node, the conduction is coming from the AV node, kaya wala siyang P wave dito. So this is a QRS, pero nandito na yung P wave mo because the electrical impulse started at the AV node, it will conduct to the ventricles, it produced a QRS complex, pero it will conduct to the SE node, and that's why it's able to produce this inverted P wave. All right. So junctional rhythm is characterized by bradycardic rhythm below 60 beats per minute, but there is no P wave, but it's regularly occurring because an AV node is firing at a regular rate, and it should be a narrow complex QRS because it's coming from the AV node. And then the conduction to the ventricles is still on the normal conducting system. It's not through muscle to muscle, and that's why it will be like a narrow complex QRS. This is different from idioventricular rhythm because an idioventricular rhythm, it means to say that somewhere in the ventricles, let's say an infarcted myocardium is firing, and so it will produce a bradycardic rhythm. So there is bradycardia, but there is no P wave, and then there is a wide complex QRS because the conduction is not through the normal conducting system. The conduction of the electrical impulse is through muscle to muscle. That's why it's a wide complex QRS. So to differentiate between a junctional rhythm, this is bradycardia, no P wave, but narrow complex QRS complex. This is so different from atrioventricular rhythm because the atrioventricular rhythm has no P wave but has a wide complex QRS. Yun lang pagkakaiba-iba nila. So, normal sinus bradycardia, PQRST, narrow complex QRS, but bradycardic. A junctional rhythm is bradycardic, but no P wave, narrow complex QRS. An idioventricular rhythm is also bradycardic, no P wave like junctional rhythm, but it has a wide complex QRS complex. So to differentiate between junctional and idioventricular rhythm, it's on the wide complex QRS because both have no P wave, both are bradycardic. The difference is that the QRS complex is wide in idioventricular rhythm and it's a narrow complex QRS in junctional rhythm. Okay? Hi. So that's an example of a junctional rhythm. There is of idioventricular rhythm. There is no P wave. It's bradycardic, but it has a wide complex QRS. If this is a narrow complex QRS, I would say it's a junctional rhythm. All right. How do you say it's a wide complex QRS? It's more than 120 milliseconds or more than 3 small squares. Okay. This is another bradycardic algorithm. We call it a systole. ito yung pinakamadaling ma-diagnose kasi wala na talaga, pa-flat na siya, mamaya patay na yung pasyente. But be very careful because sometimes hindi lang pala naka-attach yung leads sa pasyente. Kaya siya flat. Pero yung pasyente mo gising na gising, isi-CPR mo na siya kasi asystole. Pero gising na gising yung pasyente. So there must be some clinical correlation here. You have to make sure that the leads are properly attached. Ito naman yung tinatawag na agonal rhythm, yung parang mamamatay na talaga yung pasyente. So there are just some like P waves or a little bit of ventricular waves, pero wala, mamamatay na talaga yung pasyente. It's not like a PQRST relationship. Hindi siya AD-ventricular, hindi rin siya junctional kasi irregular naman siya. It does not follow anything, all the bradycardia algorithm. This is something that we see after doing a CPR and then you have given epinephrine and then you have given all the medications, but eventually you have decided to stop doing CPR. So bago mamatay yung pasyente, ito yung nakikita mo. So we call it agonal rhythm. After the agonal rhythm, eventually you will see the asystole. Okay? Let's clarify some things. Ito lahat ang slow algorithm. You have to look for regularity. If it's regular, if there's a PQRS, it must be a sinus bradycardia. If it's a sinus bradycardia, look for PR interval because it can be a sinus bradycardia with a first degree AV block, or it can be a sinus bradycardia without a first degree AV block. Now, if there is no PWIG, dalawa lang yan. It can either be a junctional rhythm or atrioventricular rhythm. To differentiate junctional versus atrioventricular, you look at the QRS complex. If it's narrow, it's a junctional rhythm. If it's a wide complex QRS, that's atrioventricular rhythm. Now, if there is no relationship between PQRST, that's the third degree AV block, but the R2R interval is regular, the P2P interval is regular, but the PR interval will be different in all beats and that there will be complete atrioventricular dissociation. We have not talked about atrial fibrillation because I will talk about it in tachycardia algorithm. When we say atrial fibrillation, there are no P waves, just fibrillatory waves. However, the ventricular rate is irregular. It can be normal rate, 60 to 100. It can be slow rate, less than 60, or it can be a rapid ventricular response, more than 100 beats per minute. So if there is a P wave, but there is abnormality in PR interval, that's a second degree AV block. So if the PR interval is fixed in all beat with a drop beat, that's second degree AV block type 2 or Mobitz 2. But if the PR interval is changing, meaning longer PR interval before the drop beat and narrow PR interval after the drop beat, then that's a second degree AV block type 1 or Mobitz type 1 or Wenckebach. Any question?